enrich efforts in addressing current and future public health threats. So I'd like to welcome each one of you to this workshop today. And just before we start, I want to let you know that we will be having panel discussions. So we'll have 2 panel sessions. And these are very interesting, engaging sessions, and we want each one of you to stay to the end. But just before we do that, I will invite the head of programs, AFINET, he's Dr. Ditu Kazambu, to just give us a brief about AFINET and as well as welcome the board chair of AFINET. Let's give up for Dr. Ditu as he comes up.
Thank you very much, Rachel. Good afternoon, everybody. Yes, AFNET stands for African Field Epidemiology Network. We are based in Kampala, Uganda. Okay? You are going to hear more about AFNET during our discussions. But right now, I'd like to take this opportunity to invite the AFNET board chair, the AFNET director in South Africa, and the director of South Africa FETP, Dr. Lazarus Kuonza, for his welcome remarks.
Good afternoon, everyone. It is my honor and pleasure to welcome you all to this workshop. The workshop, like you have heard, has been organized by the African Field Epidemiology Network in collaboration with TEFINET. The theme for the workshop is strengthening global preparedness for pandemics, looking at the role of field epidemiology. So this workshop comes at a time when the world, as we are all aware, the world is still recovering from the devastating effects of the COVID-19 pandemic, which exposed a lot of weaknesses within our health systems. And the world is now facing an epidemic of mpox, which I think you are all aware, which started in Central Africa and has now spread to a growing number of countries over the past few months. And just over a month ago, the WHO determined that the rapid increase in mpox cases constitutes a public health emergency of international concern, according to the international health regulations. As we are gathering here today, many field epidemiologists trained through our field epidemiology training programs are working tirelessly responding to numerous public health threats across the African continent and the world over, including the mpox epidemic, which I just alluded to. AFINET continues to work closely with the ministries of health across the African continent to strengthen the capacity of the countries to prevent, detect, and rapidly respond to these public health threats as they arise, with support from many partners that we work with, including the US CDC, Africa CDC, the World Bank, TEFINET, the WHO, and many others, which I'm not going to name. On behalf of AFINET, I would like to appreciate all the support that we continue to receive from our existing partners. And we welcome new partners who would like to work with us to improve the health systems in Africa. Over the next few hours, we are going to hear about some of the work that we are doing on the continent to strengthen the health systems of the different countries on the continent. The presentations and the panel discussions will highlight some of the work that AFINET is doing to improve the health security of the continent. I welcome you all to listen to the conversations, and to participate in the discussions. This is a good opportunity to share knowledge and experiences, given that we have people coming from across all the continents of the world. So feel free to participate in the discussions, and I wish everyone fruitful deliberations during the workshop. Thank you.
Thank you very much. Right this moment, we will have a presentation from the head of programs, AFINET, Dr. Ditu Kazambu, who'll be coming up now. Thank you.
Thank you very much, Rachel. Good afternoon once more. My talk is going to be on the Global Health Security Agenda, AFNET's contribution. As you may know, our organization, AFNET, has been working since 2005 in collaboration with so many partners, and we have been implementing some of the activities across the African continent. This is the outline of my presentation. I'm going to talk about the Global Health Security Agenda, which is a global effort launched in 2014 to strengthen the world's ability to prevent, detect, and respond to infectious disease threats. It's a group of more than 70 countries, international organizations, and private sector that have committed to working together to ensure a world safe and secure from infectious disease threats. To implement this, they came up with next-gen packages with 9 areas that include antimicrobial resistance, biosafety and biosecurity, immunization, laboratory systems, legal preparedness, surveillance, sustainable financing for preparedness, workforce development, zoonotic disease. All these areas facilitate regional and global collaborations toward global health security agenda in line with the international health regulations of 2005. But at AFNET, our activities are mainly based in 5 areas of these action packages. Those include workforce development, immunization, biosafety and biosecurity, laboratory systems, and surveillance. Under workforce development, we have implemented the FETP, which is the Field Epidemiology Training Program, which is a competency-based, mentored workforce development training programs. It aims to improve field epidemiology knowledge, skills of public health workers, improve countries' epidemiology capacity to prevent, detect, and respond to public health threats. The key competencies for this FETP training is public health surveillance, field investigations, planned epidemiological studies, scientific writing and communications. All the above directly contribute to global health security through strengthening national, regional, and international public health systems. The target is one trained epidemiologist per 200,000 population, and one trained veterinarian per 400,000 animal units, or per 500,000 population. It seeks to develop prevention, detection, and response activities conducted effectively and sustainably by a fully competent, coordinated, evaluated, and occupationally diverse multi-sectoral workforce. This is the AFNET coverage in the sub-Saharan Africa region. As you can see, we are almost in all the sub-Saharan countries. Maybe now I can say except in Gabon, but we are covering almost all the countries. What have we achieved so far? We have trained 3,067 FETP in our advanced FETP programs, 993 in our intermediate FETP programs, and 13,659 in our frontline FETP. When you look at the numbers, you might say, yes, it is enough. It is okay. We've done a lot. But when we look at the needed epidemiologists, when you look at the blue color, the blue graph, that's the number that we need for epidemiologists in Africa, in sub-Saharan Africa. In orange, that's the cumulative number of graduates, I mean advanced and intermediate FETP. Now the gap, that is in gray, I think you can tell for yourself that there is still a need to train more epidemiologists in our region. Here, we're just looking at the front line. That's for our 3-month program. When we look at the needs, we need like more than 25,000 people trained. What we've achieved so far is 13,659. And we still need 1,793 more. I'd like to talk a little bit about our core, the AFNET core of disease detective, which is called the ACCORD. This core was established in 2018. It's a civil voluntary professional service of culturally competent field epidemiologists built on the One Health approach. The memberships include graduates and residents of FETP in Africa. I think in each country where we have trained our residents and graduates, we have the ACCORD. We have membership graduate and graduate residents of FETP in Africa. They are from advanced FETP, intermediate FETP, and also front line. Maybe you have seen some of them in your countries. This is the jacket that they put on. When you see the helicopter, that's where they intervened during, they were deployed during the 10th EVD outbreak in the GRC. So they've been all over in the country. I think some of you have seen them in your respective countries. These are some of the pictures on the activities in the field. The other area in which AFNET has made some contribution is on immunization, mainly on polio eradication and immunization strengthening system in Africa. We have intervened in capacity building in Africa region with a focus on polio eradication, routine immunization strengthening, new vaccine introduction, strengthening of disease surveillance, and we have got over 100 projects in 20 countries in Africa. Most of these activities are implemented with the financial and technical support from the US CDC. Other projects that we are still having is N-Stop in Nigeria, in Uganda, GHSA Uganda, polio outbreak response in Somalia and Madagascar, N-Stop in South Sudan, civil registration and vital statistics in Kenya, civil registration and vital statistics still in Kenya, and data improvement teams in Uganda, the Zambia Civil Registration and Vital Statistics and Immunization Project, a strong technical assistance for routine immunization training in Kenya. Also still have some activities in GRC and data quality project in South Sudan and Kenya. The other area where we are contributing is in lab. We have conducted some activities. We supported the implementation of quality management system for public health laboratory in over 55 labs, obtained international accreditation. We developed national lab strategic plans for 10 Caribbean countries. So we are not only in Africa, we also work outside Africa. Then the implementation of these EQA schemes using DTS panel and digital PT panel from One World Accuracy. We also supported the laboratory information management system through the development of an electronic equipment maintenance tracking tool for laboratory diagnostic equipment in Nigeria. In Jamaica, the project is supporting the scaling up of the Senate list platform and linking it to all the laboratories in Jamaica. This is being carried out in partnership with Caribbean Region CDC Office, Ministry of Health, and CARFA in Jamaica. There is a COVID-19 data dashboard development in Dominican Republic. Response to COVID-19 pandemic in Horn of Africa, that's Somalia, Djibouti, Eritrea, Dominican Republic, Angola, and other countries in Caribbean region and South Africa. Supported procurement and distribution of COVID-19 diagnostic kits, implemented quality assurance for COVID-19 diagnosis, developed guidance, documents, and training material for COVID-19. Recently, Africa CDC, AFNET, ASLM, and CHI launched training material for COVID-19 rapid antigen diagnostic kits. Still under laboratory, we did a pre-qualification of diagnosis, supporting evaluation of test kits in selected countries, field validation of multiplex assay in Nigeria and Cameroon, supported acute febrile illness study in Cameroon. Under surveillance, conducted operational research project to support the control and elimination of onchocerciasis and LFV were conducted in this period. That's between 2018 and 2023, where we did a comparison of PCR method for Onchocerca volvalis detection in skin snip biopsies in DRC, evaluation of onchocerciasis transmission in Tanzania in 2015, characterizing reactivity to Onchocerca volvalis antigens in multiplex bead assay in Uganda and Ethiopia, detection of Onchocerca volvalis in skin snips by microscopy and real-time polymerase chain reaction in Cameroon. Those are the countries. In blue, you are seeing those are the countries where this surveillance and operational research were conducted. You can see we've got DRC, we've got Kenya, Ethiopia, Tanzania, and other countries. Still under surveillance, there were some operational research projects to support the control and elimination of onchocerciasis and alpha. Oh, sorry. Yeah, I think I've already talked about this. In conclusion, ladies and gentlemen, AFNET has made huge contribution to the global health security agenda, but there is still need to train field epidemiologists in the continent. AFNET is open to collaborate with partners in the following areas: workforce development, epidemic preparedness and response, public health informatics, and strengthening the global control to climate change and others. Thank you very much.
Let's give another round of applause to Dr. Ditu. Thank you very much for giving us a broad perspective of the work that AFNET is doing across Africa and beyond. And right now, ladies and gentlemen, we'd like to have our first panel discussion, first panel session. And our first panel session is titled Lessons Learned from Managing Epidemic and Pandemic-Prone Diseases, the Successes, Challenges, and Opportunities. So I'll invite our panelists for the first panel to come up. We have the first panelist is Dr. Ben Masira. He's an epidemiologist and coordinator of ACCORD, which is AFNET Corps of Disease Detectives. Dr. Ben is also a medical epidemiologist, and he has over 10 years of experience. Let's clap for Dr. Ben as he comes up. Second panelist, Dr. Chukuma David, who is a senior technical officer at AFNET. He also has 18 years experience in epidemiology. Let's clap for Dr. Chukuma as he comes up. Dr. Patrick Nguku, who is the regional technical coordinator for Nigeria. You're most welcome, Dr. Patrick. We'll have Dr. Kevin Mugenyi, who's a senior epidemiologist, and he's in charge of immunization programs at AFNET. You're most welcome, Dr. Kevin. We have Dr. Sisi Juru, who's a technical advisor of the Zimbabwe Field Epidemiology Training Program. Dr. Sisi has over 10 years of experience in public health, and she works with the Zimbabwe FETP. We'll have Dr. Belinda Malasi, who's from DRC. She's a field coordinator of the DRC FELTIP Intermediate Program, which is the 9 months training. You're most welcome, Dr. Belinda. So we have a panel, and then we have our first moderator. My co-moderator is Dr. Christine Chihembo, who will come to take on the first set of a discussion. You're most welcome, Christine. Let's clap for Christine as she comes up.
Thank you so much, Rachel, and good afternoon, ladies and gentlemen. Welcome to Cape Town and welcome to this site event. We will delve directly, and Dr. Deitu has nicely taken us through what AFINET is doing towards global health security. Now we are delving into the nitty-gritties a bit, and we're getting a bit granular. So we're going into the first part of our panel discussion. And ladies and gentlemen, when you have a question, please jot it down. We'll have an opportunity for that, to answer the questions at the end of the panel. So let's go directly to and start the panel discussion. And we'll start with you, Dr. Chikuma. Can you kindly give us an overview of AFINET's work in field epidemiology and kindly highlight how the network has expanded across the continent and focusing on the post-training engagement of these FETP graduates.
Yeah. Thank you very much, Christine, for that question. Let me take us through a bit of memory lane on how these have evolved, just like mentioned in the last presentation Ditu presented. AFINET started in 2005 as a network alliance of countries providing field epidemiology training in Africa, in sub-Saharan Africa. It started as, with 4 member countries, including Kenya, Ghana, Uganda, and Zimbabwe, with a headquarter in Kampala, Uganda. The main focus of the network when it began was to provide a platform to train culturally competent field epidemiologists that strengthen the health system at the primary level. And it started with a 3-tier training model where they train the first level frontline epidemiologists that are trained for 3 months. And you have the intermediate level 9 months intermediate epidemiologists, FETP, that trains for 9 months. And then you have the advanced level epidemiologists that train for 2 years. And in each country where this training holds, you have some adaptations that suit the country needs. And it's usually a partnership between the AFINET, the Ministry of Health, or the National Public Health Institutes in the country, and also the Ministry of Environment, Ministry of Agric. So using the One Health platform. And in most countries, it also involves the academia, providing this training to mostly in-service training to health workers drawn from the health sector, from the animal sector, from the environmental sector also. So when these people are trained, because most of the time they are drawn from the in-service training, they are almost 95%, almost 100% absorbed back into the training, post-training, and it helps strengthen the health system in different aspects, including the surveillance system health strengthening, the program management, but apart from infectious diseases, they also provide services in public health program management, in non-communicable diseases, in injuries, and also in antimicrobial resistance. So when these people are trained, they are deployed back to their place of work. Usually, when there's incidents involving maybe a health threat, they are quickly mobilized and deployed to help to prevent this problem where they occur. Some examples we've seen can be seen from what happened early in the early stages of COVID pandemic, when these are the first level of responders that are being deployed to the point of entry to screen, to detect, to also follow up contacts and ensure that COVID is contained in different countries. Other examples we see in Africa, the 2004 EVD in West Africa, the recurrent EVD exposures in DRC, and also in Uganda. Also see their role during the Cyclone Ida that took place in Mozambique. They were very strategic in bringing immediate relief immediately after the incident. Also, places like Zimbabwe and in Zambia, where you have recurring cholera outbreak, they've been very strategic in responding to these outbreaks. Currently, the ongoing mpox outbreak in many countries, but especially in DRC and in Nigeria and other major places where the outbreaks are going on, they are being deployed to contain these outbreaks. Now, this training don't happen in vacuum. There are partners that come together with the national government to provide funding, to provide technical assistance to make this happen. And this includes partners like US CDC, the African CDC, the Global Fund, the WHO, and then many other, Bill and Melinda Gates Foundation, and many other partners that are involved in providing this funding and technical assistance to make this happen. Thank you very much.
Thank you so much, Dr. Chikuma. Indeed, that's some good work supported. Let's now move to Dr. Ben Masira. We've heard of the ACOD, the Affinate Corps of Disease Detectives. Kindly, could you tell us how these are mobilized and what role they play in pandemic response as well as cross-border deployments?
Thank you so much, Dr. Christine, and thank you for inviting me to talk about this platform of ACOD. As Dr. Ditu indicated, this platform is a platform for residents and graduates to be able to effectively respond to the frequent epidemics and other public health emergencies within our region, Africa. So this idea was conceived way back in 2011 to establish a platform where our FETP residents and graduates can contribute to the frequent emergencies which we experience as a continent. So in 2018, it was launched in Kampala, and then that was also followed by regional launches. In this region, the South African region, we launched it around 2019. So this is one of the affinity-based interventions for us to be able to support preparedness and response activities, not only in Africa, but even beyond Africa, as you have heard Dr. Ditu mention, that we also support some countries in the Caribbean region. So in terms of where these ACOD are, I know Ditu, you have touched on this, but I have to emphasize that they are distributed within our network of 40 countries, and South Africa here, where we are now, is one of those countries where these ACOD members are. And when it comes to their mobilization and deployment, immediately after the launch in 2018, we received a lot of feedback from partners, like partners who are here, about how to streamline their operations to maximize efficiency during deployment. So one of that feedback was having an SOP. So we immediately came up with an SOP on deployment that guides us as we deploy these ACOD. We also shared this with our partners, like the Ministries of Health and other partners. So whenever there is an outbreak, let's say in South Africa, we receive a formal request from the Ministry of Health. And this request goes to the ACOD in-country focal point. And for this case in South Africa, actually and elsewhere, it is the program director. So in South Africa here, it is Dr. Lazarus, who is our ACOD focal point. So he works with the resident advisor in the country to do some quick mobilization of these ACORD members to know who is available for deployment based on a specific outbreak. So when we are deploying, we consider the aspect of One Health. We put into consideration the veterinary side, animal side, and other environment and other sectors as well. So as we are mobilizing, we put all that into consideration based on the nature of the outbreak. So in the meantime, in each of these countries, we maintain a database for this ACORD. Each country has its own database where we, with contacts and other details, where we can easily mobilize these individuals. So the resident advisor with the program director, they come up with the budget and then submit it to our regional coordinator. In this region, you have Dr. Noshon Gombe, who is also here with us. So once it reaches his desk, it is sent to AFNet Secretariat in Kampala for consideration. Now, we receive several requests each day or each month, and unfortunately, we may not be able to fund many of them. But we work closely with partners like the US CDC, Africa CDC, the World Bank, and other partners. They have been very critical in filling this vacuum we have at the Secretariat, but definitely they still need for more funding of this platform. So once we have finalized the selection of these individuals, we normally take them through a 1 or 2 day pre-deployment orientation. This orientation looks at the epidemiological situation of that specific outbreak, signs and symptoms, contact tracing, how it will be done. We also discuss the terms of reference, security issues like we are facing in this region. Many countries are going through that, security challenges. So security issues and other issues that are related to deployment. And once that has been done, our ACORD are normally integrated within the surveillance pillar, and they work within the incident command of a particular emergency. So we deploy them in the field, and they work alongside the Ministry of Health rapid responders as well as other partners. And they engage in things, issues like contact tracing, surveillance, border health, risk communication, and a number of other critical areas for outbreak response. Now, in terms of funding, we have 2 funding mechanisms. The major one is through our partners, but we also use our own funding as AFNet whenever possible. So I think, Dr. Christine, I can end it there, and thank you so much.
Thank you so much, Ben, for sharing those insights. So let's move to Dr. Belinda. Dr. Belinda, we know that DRC is one of those countries that has been affected and experienced several outbreaks, including Ebola, Marburg, and the now ongoing Mpox. So how have field epidemiologists from the DRC FELTIP contributed to the outbreak response, and what are the key lessons that have you learned from that experience?
Thank you, Christine. Someone says that every minute in DRC, there is an epidemic is going. And for a deployment of FATP in DRC, we say that is the most of crucial step to stop a spread of diseases in our country. As I say, the deployment of FATP is a very big process. We begin, first of all, by the meeting with MOH, with WHO and other partners, I mean US CDC and CDC Africa, to identify how many FATP must be sent to the field and which geographic zone is affected. And secondly, after that meeting, when we agree to deploy them, The target is to obtain the clearance and also to make a travel arrangement. As you know that in DRC we have a accessibility challenge. And after that, when epidemiologists are in the field, if I say epidemiologic, I mean that there is a resident or a graduate, and for all profile, they can be AP, they can be veteran or lab. And when they are in the field, the coordinator follow them in the ground and make sure that they do what objective they. I beg your pardon, I'm from DRC, and in DRC we speak French. Now I make an effort to speak in English. And then in the field coordinator must follow them and to be sure that they done what they were sent. I mean identification or monitoring cases, to follow up contact, to implementing a strength local capacity in epidemiology, and to support laboratory activity. And in the end of that deployment, we do also a debriefing with that accord, like Dr. Ben has said. There can be a code or a resident to present the results of the field. That is in general. But there is a specific cases. As you mentioned, at DRC, we have many challenges. Sometimes we deploy FATP to the country which has a network challenges. And then we must be sure that they can find somewhere they can send data. And sometimes we use the other means. In French, we say phony, touraya. I don't know in English what is the tradition of that. And sometimes there are FATPs who are sent to the country with security challenges. The example is with Ebola. In 2018, we sent around 212 FATPs in the field to North Kivu, South Kivu, Uturi, and also at Equator, what is the area with a network challenges. And there, the program must conduct with UNS agency organization for a safety of the FATP, and sometimes we ask the FATP to do a safe training before to be deploying to the area with security challenges. And for that current epidemic of Mpox, with a fund of CDC, USA CDC, we have deployed 95 FATP in the field in 7 provinces. And they are in the area who are all the challenges I mean earlier, the security challenges, the network challenges, also the outreach challenges. And as we know, the DRC is a lead of country who notify more cases of Mpox, and there is a large plan of deployment of FATP to the field, but most of the challenges is the found. We have not found earlier, and sometimes we have challenges of obtaining the clearance of Ministry of Health, and in DRC, we have not a strong network of laboratory, and we use sometimes a mobile laboratory we use sometimes the mobile laboratory, but other lesson we learn about that outbreak or response that is more easily to use a local workforce. If you use a local workforce, it's more easy because, as you know, DRC has accessibility challenges. We have not enough airplane. It's more difficult to send to the field epidemiology. Other lesson we learned is about the inter-epidemic period. They must be capitalized to update templates, to update the guideline, and also to make a simulation exercise. And other lesson we learn for DRC is about an emergency fund. The country must have the emergency fund which can be mobilized if the outbreak appeared. But the challenge is enormous in DRC. The funds are not available on time. A delay of clearance is too long. Accessibility challenges, security challenges. But one of the challenges is to make the One Health approach in DRC. I think that is the lesson learned with the support of FATP to the outbreak in our country. Thank you.
Thank you so much, Belinda. Ladies and gentlemen, the challenges are many in the DRC, but nevertheless, our graduates are there to respond and have adequately responded. Let me now pass it on to Rachel to take us through the second part of this panel. Over to you, Rachel.
Thank you very much. Once again, let's give our first round of panelists an applause for the great work that they're doing and for sharing with us. So over to Dr. Kevin Mugenyi, who's in charge of immunization at AFINET. So VPDs, vaccine preventable diseases like polio and measles, are resurging in many African countries. So how has AFINET worked to curb these outbreaks, especially working with the partners who are already on ground, Ministry of Health, CDC, WHO, and many others?
Okay, thank you very much, Rachel. Indeed, as you mentioned, the African continent continues to suffer from many outbreaks of vaccine-preventable diseases, including poliovirus outbreaks. We've seen outbreaks of circulating vaccine-derived poliovirus in different regions of the continent, including Western Africa, where we have outbreaks in Nigeria, Cote d'Ivoire, Mali, Burkina Faso. Coming to Central Africa, we have large outbreaks of measles. For example, in the DRC, we have got outbreaks of circulating vaccine-derived poliovirus in the Central African Republic. The Horn of Africa, Southern Africa, Malawi and Mozambique recently had an outbreak of wild poliovirus. So the problem is real, and indeed, AFINET has played a key role in working towards the response to these outbreaks. So our response is really grounded in a strong partnership with the ministries of health in the different countries in which we work. So we have got partnership with the ministries of health, partnerships with key partners like the US Centers for Disease Control and Prevention, the World Health Organization, Gavi, UNICEF. So it's really a multi-partner and multi-sectoral approach to tackle these enormous challenges. And the approach AFINET has had has included really the deployment from our wide network of experts, just like my colleagues have mentioned, ACCORD, the FETP graduates and residents, and in addition, a network of experts from the Global Polio Eradication Initiative. So there's also a network of experts that are deployed from the GPI partnership as well. And these experts are rapidly recruited through AFINET's efficient human resource system that rapidly recruits these experts and deploys them to the field, making sure that the logistics that they need are also available and they are deployed to respond to outbreaks in a timely manner. So some of the activities that these experts conduct in the field include planning, implementation, monitoring, support supervision, ensuring that high quality supplemental immunization activities are conducted, and they work again in close partnership with the Ministry of Health and other partners on the ground. And in addition to these activities, they also support new vaccine introduction activities, vaccine surveillance and vaccine safety activities on the ground. So there are a number of achievements that the technical experts for immunization have achieved in the different countries where they've deployed. We need to maybe mention that we've deployed over the last 10 years over 18,000 FETP graduates and resident deployments across over 20 countries across the network. So they have indeed contributed towards the timely control of outbreaks in the different countries and regions where they've been deployed. They have also contributed to improving performance indicators for routine immunization, such as coverage, dropout reduction, and have also contributed to the improvement of vaccine-preventable disease surveillance indicators in the regions where they've been deployed. For example, polio surveillance indicators that are tracked, such as the non-polio AFP rate and non-polio enterovirus rate, have been observed to improve in the regions where they've been deployed. So, notwithstanding the great work they've done, there have also been challenges, some of which have been mentioned by my colleagues. Financing is a major challenge, sustainable financing, because as you can imagine, the work that is being done is really resource intensive. So there will really be a need for continued resource mobilization for this great work that is being done. And also a lot of the technical experts that are deployed in very difficult areas like Dr. Belinda mentioned in the DRC, hard to access areas and areas of high insecurity. So briefly, Rachel, that's what I would have to share for now. Thank you.
Thank you very much, Dr. Kevin. Over to you, Dr. Sisi Juru. Zimbabwe has experienced a wide spread of current resurgent outbreaks of cholera. And how has AFINET, through Zimbabwe FETP, supported the response of these outbreaks? And how have you also been involved in preparedness efforts for future cholera outbreaks?
Thank you very much, Rachel, for that question. So indeed, cholera outbreaks have been a significant public health concern in Zimbabwe over the last 2 decades or so. I think the first case of cholera in Zimbabwe was recorded in 1972, and since then, we have had the largest cholera outbreak, which happened in 2008 to 2009, and we had over 4,000 cases of mortality. And the driving forces really for this cholera outbreak was mainly issues to do with water and sanitation. And at that point in time, there was also economic challenges. You would think that from that big outbreak would have some lessons learned and make some improvements to our WASH services. But since then, we've had a number of outbreaks that have been occurring and reoccurring because of seasonal rains and, of course, WASH issues. We had an outbreak in 2018 and 2019 that recorded over 10,000 suspected cases. And from there on, AFINET, through the Zimbabwe Field Epidemiology Training Program, supported the deployment of about 35 residents who went into the field. And they were conducting a number of activities, of course, in collaboration with the Ministry of Health and Childcare. They were doing activities, contact tracing, case investigation, assessment of case management practices, especially in areas where there was high mortality. They managed to organize 2 health campaigns in Harare City, which was the epicenter of the outbreak. And data management, data analysis, and all of this work was being done in collaboration with the ministry to come up with daily situational CTREPs that were being used to inform decision making. And of course, we cannot talk about FETP and not the research that they will do in addition to all of these activities. So there was a lot of research that was conducted, and the recommendations for some of this research was used to inform a change in policy or treatment guidelines. Coming to mind is one study that was done looking at the samples that were taken from the confirmed cases, and it was determined that about 70% of the samples that were collected were resistant to the first line of antibiotic treatment, the tetracycline group of treatment. And there were some changes that had to be made then to include azithromycin to treat severe cholera. And that was a big change, and it emanated from the work that was done by FETP residents. Again, you would think that we would learn, but then things always happen that we come up with all of these recommendations following an outbreak, but then the implementation then doesn't take place, because as you would have it, In 2023, in 2024, we experienced another cholera outbreak that spread also to the other countries. Zambia also recorded some cases of cholera. There were over 34,000 suspected cholera cases, over 4,000 confirmed cases for that cholera outbreak. In Zimbabwe, it was then declared over in August of 2024. Again, AFINET, through the Zimbabwe Field Epidemiology Training Program, supported the deployment of about 20 residents to do more or less of the same activities that were in response to the cholera outbreak. I think AFINET has done quite a bit of work when it concerns responding to the cholera outbreaks. But one of the questions that you raised of what do we do as AFINET or Zimbabwe FETP to work with the Ministry of Health in preparing for outbreaks? Because it seems as if as long as we are not addressing the key issues on the ground, we're always going to be talking about cholera outbreaks every other season, as and when there is rainfall. So as Zimbabwe FETP, maybe let me give a bit of a background to ZIM FETP, Zimbabwe Field Epidemiology Training Program. It's a joint program between the Ministry of Health and the University of Zimbabwe, embedded within the Ministry of Health, which makes it work for us because we are institutionalized. Whenever there's an outbreak, be it cholera, be it measles, we are already within the system. So at national level, because we're embedded in the system on a weekly basis, they have weekly disease surveillance meetings, which we are a part of. So we provide that technical support to the Ministry of Health on a weekly basis as we're reviewing surveillance data. When they are reviewing their policy documents, we are also part of it. I gave an example earlier on of the change in the treatment guidelines when there was cholera. All that, giving evidence to change is something that we do on a daily basis with the ministry. But also as AFINET, we lodged for funds from US CDC to train the health workers on incident management system. And in 2023 and 2022, we trained about 200 health workers at national level and also sub-national level on public health emergency management system, which is what is required when you have an outbreak. It doesn't relate to cholera only, but to all outbreaks, to ensure that from the ground level, we are all prepared to respond to outbreaks as and when they occur. So AFINET, ZIM FETP, Ministry, they have been working in collaboration to respond to all of these outbreaks, including cholera. Thank you.
Thank you very much, Dr. Sisi, for that very elaborate explanation and response structure to the cholera outbreak. We noticed that in all the presentations and all the sessions, we keep talking of the issue of funding. It keeps coming out. And Dr. Patrick Nguku, would like you to explain to us how has AFINET addressed this particular funding challenge using the example of Nigeria, particularly with the Outbreak Revolving Fund that has been piloted in Nigeria.
Thank you very much, Rachel. But before I explain, I really want to thank the audience. Yeah. You had 7 other options, but you chose this one. That is significant, so thank you very much. Please, an applause for everybody. But secondly, the president of International Epidemiology Association is in attendance. Please, Prof, stand up so that everybody sees you. That is the president of the International Epidemiology Association. Thank you very much for choosing this particular workshop. Thirdly, today is South African Heritage Day. So epidemiology is our heritage, all of us. So again, thank you for coming over. My topic is about an innovation to deal with the many issues that you've had. How do we, once we've detected, verified, confirmed an outbreak, how do we ensure that we contain it, we control it, we mitigate it so that we limit the cases and deaths? So over the last few years, we've been working with a number of partners to develop what we call a revolving outbreak investigation fund. You all understand that the responsibilities of a response is governments at all levels. But domestic funding for outbreaks is limited in the arena of things that we are doing, the social, the economic, the developmental needs of a country. And indeed, the theme of this conference is about epidemiology and complexity. How do we address these challenges to ensure that we have a robust response? And really, funding is one of it. So the challenge of dealing, particularly in our African context, limited resources. Yes, many governments do allocate resources for emergencies, but there's a difference between allocation and release and timely deployment. And therefore, we came up with this idea of revolving outbreak investigation fund that we've tried over the years, and we've actually published the initial findings on the Health Security Journal, if you want to read about it. And the idea is, can we pool resources from government, from development partners, from philanthropists, and ensure that once an outbreak is detected, notified, we institute those initial response, because that's where containment opportunities are. If we contain those first few cases, we limit the spread, but also the devastation and the disturbance that outbreaks come up with, then are limited. And therefore, in 2018, working with Resolve to Save Life, we did develop this concept about a revolving outbreak investigation fund, have dedicated resources, and ensure that within 48 hours of confirmation of an outbreak, we can deploy, but we can also procure supplies that are needed to make that initial difference. We can deal with risk-com community engagement, those initial needs, but we can also deal with trainings, those initial really very vital interventions that ensure that the outbreak is contained. And so that's what we've been working with. We've tried this in Nigeria, but at the heat of COVID, we did work with, again, Resolve to Save Life to try this in 14 other countries. And it really helped in terms of reducing response time, in terms of containing and mitigating outbreaks. I think one of the big things that we've learned is that, and you'll see it if you look at that paper, that we do demonstrate that pre the intervention, the median response time was 6 days, but we managed to reduce it to 2 days, which is like 67% reduction. So I think the call here is to partner with Affinet to expand this, even as we advocate for more domestic funding to allow such mechanism to ensure that those initial response requirements are dealt with sufficiently and significantly. I'll stop there because I talk too much.
Thank you very much, Dr. Patrick, and thank you everyone for sharing your thoughts on the different topics that you have been given. I'd like to open this up to the audience. If you have a question, yes, I'll just have a microphone. I'll have one question and then 2 and 3. We'll take the first 3, those first 3. Yes.
Thank you. Thank you, Rachel. Do I have to introduce myself? Or?
Yes.
Okay. I'm Jermaine. thank you so much to all panelists and Dr. Dito for introducing the topic. I'm an international consultant. I've been working with CDC for a long time. I have been in different countries in Africa, in DRC, South Sudan, Guinea, a few months ago. So I would like to thank all my colleagues who are here for their support. My question is, Dr. Patrick, excellent. This is I was expecting to hear. However, I know foundation is one, but there is another challenge, which is big. When you listen to Zimbabwe, DRC countries, and the doctor was talking about VPD outbreaks, they are, I have, my experience is they are people work in silos. So they are echoes. They are there. I think they are, if you look at DRC in other countries, they are. But if it's an outbreak in Zimbabwe, you'll never get echoes from Zimbabwe, from Guinea going to Zimbabwe. I know maybe because of the language, but it's more than that. The time, the response time is going. But even close country, I'm giving an example between Kenya and Uganda. We had an outbreak in September, Ebola. But to get people from Uganda going to, so can you, I don't know, I know CDC, Africa CDC can help. Can you find innovative ways to bring all those African countries to one time to sit together and say boundaries, disease don't have boundaries. How can we reduce the time to deploy skilled and experience? I'm talking about experience. Instead of training, retraining again people, you have already echoed. How can you reduce this time? Thank you so much also to the president of the International EP Association for being here. Thank you so much for choosing this topic and the workshop. Thanks. So my question, if I come back, I'm sorry for talking so long. What would be, from you, Dr. Patrick, the best approach to reduce, to facilitate collaboration or partnership, I don't know, between different African countries? Thank you.
Thank you very much. We'll take the second and third question, and we'll answer those three first.
Thank you very much. My name is Jacob Gizamba, and I'm a PhD student at the University of Southern California. First of all, I want to thank the panelists and AFNet for the great work that they are doing to address public health issues in Africa from an epidemiological perspective. My question is, I guess it goes to all the panelists. You talked about different outbreaks in Africa and how AFNet is trying to address that. But I was curious to know what you're trying to do regarding non-communicable diseases, because Africa seems to be experiencing a double burden of diseases whereby we're having infectious diseases still ongoing, but we're also having a rise in non-communicable diseases. So I'm curious to know what AFNet is thinking about that. Thank you very much.
Good afternoon, everyone. My name is Kennedy from Zambia, a FETP resident. My question goes to Dr. Belinda. You mentioned a lot of challenges that Congo is facing in response to disease outbreaks. So my question is, have you ever had a situation where a team of FETP response teams, especially in the eastern DRC, came under rebel attacks, and what is being done to ensure that their safety is well guaranteed? Thank you.
So as the moderator consults, let me take my question from my brother. We talk too much. Surveillance and response is like politics. It's local. So I think we really have to think about how do we capacitate those local capabilities and capacities. I think that's it, whether it's training, whether it's the lab, whether it's the surveillance system, whether it's the coordination. And I think that's why African CDC has taken this leadership role in terms working with AFINET and other partners in Africa to support countries to create national public health institutes. Because that's where the coordination is, that's where the advocacy is, that's where you push the IHR technical areas and ensure that the needs for early detection and response are there. And I think the other bit is for all of us working in this space as epidemiologists to think about how do we make our epidemiology practice consequential? How do we advocate for more domestic funding for those levels? How do we support this community health training and ensuring that we have community health workers to as near the local level as possible to help not only with the UHC agenda, but also the health security agenda. So it is, my brother is a professor. It's, I think, a joint, yeah, you are a professor, joint effort for all of us to push this agenda. Thank you very much. There was a question for...
It's about security challenges. I will give my own example. When I was at Ebola EVD, at 2018, I think that Dr. Ditu remember that day, there was a very serious problem of security in Beni. And we were under responsibility of MOH, but it was very difficult to organize our evacuation. I think that Dr. Ditu contact the MOH, who, with the system of security, they done our evacuate to Beni from Beni to Goma. I think it's a very big challenge, but we conduct a local responsibility or a local team to help our codes. And also we can conduct other organizations like UNS agency. They have the system of security. They can do their best to evacuate the our code. But it's still the very big challenges. Thank you.
Yes, Dr. Chukuma. Just Dr. Chukuma, 1 second, and then Dr. Ditu will respond to the question on NCDs.
Yeah, thank you. So I want to add my voice to the first question on working in silos. Apart from working in silos in terms of country, even within countries, we also notice that people work in silos and people want to work maybe animal health on their own, environmental health on their own, and then human health on their own. Our experience has been that when you train together and you deploy together, you're able to breach those silos and allow for cross-sectoral collaboration, both in training and in deployment. So we'll encourage countries, when you are doing your training, don't train individually. If it's possible, train together and then deploy together. That also helps the systems to communicate to each other and work better together. Thank you.
Thank you, Dr. Chukuma. Dr. Ditu?
Thank you, Rachel. I'd like to respond to these two questions. The one for Dr. Belinda and the question on NCD. First of all, we need to know, like, we talked about the situation in the DRC. Yeah, most ACOD members in DRC are civil servants. They belong to the Ministry of Health. Okay? So even when we are training them, they're still part of the Ministry of Health. So we discussed with the Ministry of Health before deployment to see how these people can be evacuated in case of a problem. And in most cases, the Ministry of Health will collaborate with WHO and other UN agencies to make sure that when there is a problem in the field, if there is need to evacuate people, these ACOs should also be considered. That's what it is in the papers. okay? But with experience, we've seen like when there is a problem, they prefer to take UN, what can I say, workers first, to evacuate them, then they leave our accord. Then you have to make a lot of noise for them to go back now to start looking for them. Unfortunately, this is what happened. But now I think the ministry is a bit conscient. I think they're going to deal, they've started dealing with that issue in advance. Okay? Because when we try to tell them, okay, we said we can look for maybe a private sector, they said no. The accord are the civil servant. They work for us. They work for the government. They are government employees. So it is the duty of the government to look after their safety. Okay? Yeah, on the question for the non-communicable disease, it is true, it is not a threat. I think long back when we were doing the FETP training, the focus was on infectious disease. But right now, I think we are conscious of the threat from the NCDs. There is a program, I can say. There is something that is already in the pipeline where we are trying to include NCD in the curriculum. There was already a workshop in Kampala that was between AFNet, organized by AFNet, CDC, and TEFINET, where we had some case studies that were reviewed and were sent back to CDC Atlanta for review. Maybe when they finalize the case studies, they'll be included in our FETP training on non-communicable diseases. Thank you.
Thank you very much. Dr. Ben, you'd like to add something?
Yeah. I wanted to add on the issue of deployment of ACOD from other countries. Let's say there's a problem here in South Africa, and then we deploy from Mozambique or other neighboring countries. Yes, in principle, we can do that. However, our strategy is to use in-country resources first. It is only after they are exhausted that we can now look elsewhere, like happened during the cyclone Idai, where we deployed the ACOD from other countries. We have seen situations where ACOD members from other countries are attacked when they go and support another country. So we are very cautious with that, and we prefer to use the in-country ACOD before we deploy from other regions. Then in NCDs, on top of Dr. Ditu's comments, we also have some direct projects we support. Like we have projects on cancer. In Uganda, we are running some bacterial lymphoma projects, which have actually revealed a lot of evidence around bacterial lymphoma and its how it is, acquired. And of course, there are also some projects in Nigeria on NCDs as well. Thank you so much.
Two questions from the other side. Yes. Thank you. One and then two.
Yes. Thank you so much for this very enlightening session. I'm called Amanda. I'm from Uganda. And my question is really about inclusivity. I saw from the presentation that there's, as much as there's been much training, which we appreciate, there's also a deficit, a gap in number of people. The different levels of responders, advanced, intermediate, frontline, and I'd like to think that for each country, there are other people who have not been trained by AFNet, who are able to be added to that number in terms of the deficit and the gap. So my question is there a plan to widen the scope of those who can join, and what's the gap? And I know even speaking from people who are here, some of us already have some of the skills, but would benefit from the training and therefore become part. So is there any such arrangement? Yeah.
Thank you very much, Amanda. Dr. Ben, take note of that question. We'll have the second question.
Thank you so much. This is Ruba from the Eastern Mediterranean Public Health Network. So actually, we would like to know more from your experience as a regional network about about the deployment. So my question about if you have any database for the people who can be deployed, or the criteria that you are considering for deploying people, and how you keep this database alive, and how you offer opportunities for these people to be deployed, especially for FETP graduates as well. Thank you.
Thank you very much. We'll sneak in one last question, and then we'll answer them and wrap up the session. Yes.
Thank you. My name is Pulani. I'm a student at the University of Cape Town. So my question is mostly to Dr. Juru. It seems like despite all your efforts to prevent cholera outbreaks in Zimbabwe, there's still a gap in preventing future outbreaks. And I would like to know why that's the case, and also to ask is it because of the poor responsiveness from the Ministry of Health? Could that be part of the reason why? And also about NCDs, I would like to add to the gentleman's question. I would like to know if AFINET is aware of syndemics, which could be coexisting medical problems or diseases between infectious and non-infectious diseases that just make each other worse. For example, if you have cholera outbreak, you could expect or anticipate a malnutrition to accompany that, and the two to coexist and make each other worse. So those are my two questions.
All right, thank you very much. Dr. Ben, the first two questions on accord, and then Dr. Sisi.
Okay, I'll answer the one on accord. I think one was on workforce. But in terms of these deployments, how we maintain this database, we routinely update this data as graduates enter into the program and exit. So we document a lot during their training and after training. So one of the issues we look at, where are you working at the moment? What are you, what exactly are you doing? Which country are you based at the moment? So we do a lot of documentation and try as much as possible to keep it up to date. We also have some online platform which we are developing to make sure that this is done in real time, so that we can be able to track effectively where these residents are. In terms of opportunities, thank you for bringing up that question. I remember my first time to come to South Africa. The residents were asking me one of the very important questions. They are not, this is from what they told me, they don't get very frequent outbreaks in South Africa. That's what they said. How can we benefit from this platform of Accord? That was one of the questions, you know. But in principle, as I said, if there is an outbreak let's say in Zimbabwe, and our policy is to exhaust the in-country resources first. Then if it is a very wide scale and it requires some external support, we reach out to other countries and outsource these Accord members. Thank you so much.
Yes, Dr. Sisi.
The follow-up question on inclusivity and getting more workforce. Let me draw an example from what happened in Nigeria during COVID. We noticed that the pool we had of trained graduates would not be enough. So we reached out to other agencies, other professional bodies, and we're able to update the search capacity by drawing in other trained skills within the country, so that during deployments, a team is composed of both FETP graduates and other professionals who are trained in other aspects that also needed during the outbreak, and they were all deployed together. So depending on the type of outbreak you're managing, yes, it's not limited to only those that in FETP, or those people that have within the country that have other skills that are needed in responding to those outbreaks. They are brought on board and they are deployed together. Thank you.
Thank you for that question that you raised. So Zimbabwe, indeed, like any other country, has got its own issues when it concerns responding to outbreaks. But I think we are competent in responding to outbreaks, but the challenges that, of course, that we are facing is the health workers. Over the years, we've had a number of health workers that are moving to other countries in search for greener pastures. So when you don't have a competent health workforce, or even the numbers of a competent health workforce, whenever an outbreak occurs, it may take time for you to actually pick up that outbreak and respond to it timely. I think the move right now, of course, is to have the 717 approach, where you pick up the outbreak within 7 days, you report it within, you notify it within a day and respond within 7 days. But if you don't have a competent workforce, then it becomes difficult. What the country, of course, has been trying to do right now is to train the frontline workers. In Zimbabwe, we did not have frontline workers trained in FETP before. We are mainly focused on the advanced program. And we've since started the frontline FETP in order for us to up our numbers of competent people who are able to pick up outbreaks and respond from the grassroots levels. I hope I have answered your question. Thank you.
Yes, Dr. Chikoma.
So one last comment on the NCD. There's a question on NCD from there. A number of works are ongoing on NCD. Some have been completed, like the STEP studies have been done in Nigeria and in a number of states. There's an ongoing a cohort study on hypertension that's been there in Nigeria for like 4 years now and ongoing. And also a number of buckets and informal studies that's going on in Uganda that's been mentioned, and not just in Uganda, I think also in Tanzania. And so in as much as the initial focus was on infectious disease, we are now moving away, not just moving away from it, including the antimicrobial resistance that's emerging, including the NCDs, also including the injuries. A number of residents are now focusing on injuries and accidents in major cosmopolitan cities to understand what are the things driving these injuries and how do we begin to design policies to reduce them. Thank you.
Thank you very much. Because of time, I will just ask each of the panelists in half a minute just to just tell us what opportunities are available for improvement in your various sectors, just in very short time. We'll start from my far right with Dr. Ben and move right to Dr. Kevin.
Thank you, Rachel. So for me, I will base this on our experience in the Accord platform. When we deploy people, it has really been very, very complicated, especially when it comes to the issues of data analysis, rapid data analysis to guide the decision making. That has been a very, very big challenge, yet we are now aware that we have a lot of tools, tools which are supporting us as humanity to solve our needs. For example, artificial intelligence, which I know is being, the uptake has been good in other areas, like aviation, in cars, and so on and so forth. So I think we have a challenge where this uptake is very slow within our space in public health. So I think we need to really think through on how to embrace and even integrate these new tools into our responses to solve the challenges, like especially data analysis, transmission chains analysis, and other critical areas in the response. Thank you so much.
Thank you.
Yeah, thank you so much. A lot of successes has been recorded, but if you look at the problem, it's as if a lot needs to be done. Not all the countries are currently doing all the tiers of FETP training. Only 17 countries out of 40 are doing the advanced level training, meaning that the rate at which we are filling the gap is too slow. So I want to call on partners to come on board and increase the rate at which we are developing these skills. We want to get at least the minimum of 1 to 200,000 epidemiologists is the barest minimum. It's not the optimum. And yet we've not gotten the barest minimum across Africa. So it's a wake-up call call on everybody, get interested, both the trainees, the trainers, the funders, and the government, to invest in field epidemiology training and their use, not just in infectious diseases, just like what was asked about other aspects of public health, so that every community gets the minimum they need to be able to protect the health of that community. Thank you.
Thank you so much, Dr. David. Yes, Dr. Patrick.
Thank you. Before I say my 2 points, tomorrow, TEFINET and AFINET, we have an NCD side event. So my PhD friend, please let's come and discuss a little more what to do in NCD. Epidemiology is about distribution and determinants. One of the biggest determinants for containing outbreaks is flexible funding for early response. If we are to achieve the 717 metrics and ensure that we are detecting, we are notifying, and we are responding early, we have to look for innovative funding mechanisms for response that can allow that initial deployment, that initial procurement, that initial logistics support for those first few cases. So I think let's work together to advocate for these flexible resources in all our countries, to increase domestic funding, but also to ensure that we have that funding, that health system strengthening that allows us not to be overwhelmed by outbreaks. Thank you.
Yes, Dr. Sisi.
Thank you very much. My worry is that we have become reactive epidemiologists. Whenever an outbreak comes up, that's when we all run around like headless chickens. We have all stakeholders coming in, and that's where we see that collaboration or stakeholder involvement. And we come up with a lot of recommendations of what needs to be done. But then at the end of the outbreak, when all the fire has died down, what we have left are policies changed, recommendations in place, but no implementation of those recommendations. My plea is really that at the end of any outbreak, that stakeholder or multi-stakeholder collaboration should continue even beyond outbreaks. Otherwise, we'll still, every year we'll talk about, oh, this outbreak and there was response early, but beyond the outbreak, that stakeholder involvement is lacking, and there's need for improvement in that aspect. Thank you.
Thank you, Dr. Sisi.
Thank you, Raquel. I can say that in DRC we have a lot of success story with a deployment of FATP to fight outbreak. But we have one need. We have not enough FATP in our country. And first of all, I thank all partners who help FATP program. I mean USA, CDC, Global Fund, CDC Africa, and so on. But we have a really need of training FATP in DRC. That is my last.
Thank you very much. Dr. Kevin?
Yes, thank you very much, Rachel. So indeed, a lot has been done and a lot has been achieved towards controlling vaccine-preventable disease outbreaks in Africa. I think it's key to take home the message of maintaining strong partnerships between the Ministry of Health and key immunization stakeholders. A need to work towards improved financing, sustainable financing, and also a need to work towards strengthening routine immunization, reaching zero-dose children, unimmunized children, building population immunity, as well as building resilient immunization systems across Africa. Thank you.
Thank you. Let's give it up for our panel. You have done well. Thank you very much. And as our panel stands up to leave the stage, I'd like to invite you all to stand up and stretch. It's been a very interesting session. Stand up, stretch, get to know the person on your left and on your right, and ask them if they're an epidemiologist or whatever they're doing. Yes. All right, then, thank you very much. You may have your seats. Now, ladies and gentlemen, we have a second panel, and I will invite our moderator for the second panel, Dr. Noshan Gombe, to come to the stage. You may have your seats, please. Thank you very much.
Good afternoon once more, ladies and gentlemen. I want to welcome you all again to our second panel discussion, where we'll be looking at leveraging data and technology for early detection and monitoring of outbreaks. I think you'll agree with me that in our interconnected world, the rapid spread of infectious diseases poses a significant challenge to public health systems globally. So today we will explore innovative strategies and technologies that can enhance the ability to identify outbreaks in their infancy and monitor their progression in real time. So to help us do this, we have an expert panelist who will share their insights on various tools that can transform how we respond to public health threats on the continent and beyond. So having said this, allow me to call on stage our panelists, starting off with Dr. Andy Waziri. So Dr. Andy Waziri serves as the AFNET Immunization Advisor, and prior to this, she was National Coordinator of the African Field Epidemiology Office in Nigeria. With over a decade experience in immunization in primary healthcare strengthening. She also leads the AFNET immunization in primary healthcare efforts, and she has been in the forefront of several public health interventions, including polio eradication, response to Ebola outbreak, and COVID-19 pandemic and vaccine delivery. Our second panelist is Bridget Magoba. A round of applause for Bridget. She's a technical advisor, public health informatics specialist in Sierra Leone. She holds a master's in data communication and software engineering and a postgraduate monitoring and evaluation diploma. She has over 12 years in health informatics. Thank you, Bridget. And last but not least, our third panelist. As you can see, this one is a very short one. We have Dr. Dabwiso Banda from Zambia. He is currently coordinating the advanced FETP in Zambia. So the Zambia FETP is within the National Public Health Institute. He is a medical doctor with 6 years experience working at the NPHI. So ladies and gentlemen, these are our panelists for the second session. I hope you'll enjoy it just as you did with the first one. With this, let us dive into our discussion and hear from our esteemed panelists about their experiences and visions for the healthier Africa that we all envisage. Again, let me thank you all, our participants, for joining us. I'll start with you, Bridget. As we all know, the way to go now for the integration of data systems, improvement of coordination across health systems, is digitization. AFNET has been supporting the Ministry of Health of Sierra Leone to roll out the DHIS2. Can you please elaborate how this has gone? Over to you, Bridget.
Thank you, Dr. Notion. Sierra Leone is one of the countries, the African countries, that has digitized its surveillance system. And just to take us back to the 2014-2016 West Africa Ebola outbreak, Sierra Leone had a paper-based surveillance system, and this was characterized with poor quality data, untimely, incomplete, inaccurate, and it was really tedious to have data transmitted and disseminated from the lower level to national level, and so it was difficult to make decisions. So this made the country think, how do we improve this? So in 2017, the country decided to come up with an electronic surveillance system, and with this, it was developed on DHIS2, the District Health Information System, version 2. And this system is open source, and it's widely used by so many African countries for disease surveillance. So this one that was developed in 2017 was for aggregate. So it was weekly aggregate data. So which wasn't sufficient. Again, they had to sit down and see how to improve this, because aggregate data was not enough to make decisions. So they decided to come up with an electronic case-based disease surveillance system. Looking at the use of DHIS2 the previous years, they used it for weekly surveillance, but again, they also used it for the routine monthly HMIS. So with financial support from USCDC and AFINET and other partners, the electronic case-based disease surveillance system was developed. During this time, AFINET has the lead role in the design, the development, management, and maintenance of this system. And in some cases in procurement of equipment and so on. So with all this development, the country has registered several achievements. One is the completeness improved from less than 20% to above 90% compared to how it was way back during the Ebola period. And then the timeliness. The timeliness improved, and we have cases notified within 24 hours, as I speak now. Because the electronic case-based links laboratory data to the epidemiological data and case management. So during the routine, severe case management cases are captured in the system. While during an outbreak, all the confirmed cases, data has to be captured in the electronic system. So in addition to the achievements, we have several outbreaks that have been detected and notified through the system. We've had several measles outbreaks from several parts of the country. We've had anthrax outbreaks. We've had food poisoning and other emergencies. We've had the petroleum tank and so on. So all these are notified through the system. And all this data is available. So it's available for research, and the trainees, the residents have access to this data to make scientific communication, to write publications, and so on. So all this information is available. In addition to other achievements, there are several integrations that have been done. I could give an example of the COVID outbreak. So many pillars had different systems that were being developed for different purposes. So this system was already existing by the time the country detected the first COVID case. And so the lab had a separate information system that they were running. Case management had a separate system. During that time, there was need for contact tracing. So contact tracing was added in the system, and we also added quarantine monitoring. Point of entry was also added because it was key by then to avoid inbound and outbound migration and importation of cases. We also added sentinel surveillance, as there were sentinel sites set for influenza and COVID-19 surveillance. And recently, we just added event-based surveillance. And the country has adopted the Africa CDC framework for event-based surveillance. And this is the very platform that is being used for electronic reporting, right away from community level, health facility level, up to the level of national level. So in addition to that, data analysis and use is being used across the different levels. At health facility level, at a minimal level, but district and national level, there's routine data analysis and used to make decisions, including resource allocation, If I could give an example, within COVID outbreak, the country was able to use this very data to make decisions on where to allocate which human resource, where to put more emphasis on the different activities that needed to be done during the response. And the system is a central repository of all outbreak data and even routine. So it is a rich repository of any information and data about disease surveillance in the country. Thank you. I'll stop here for now.
Thank you very much, Bridget, for those insightful comments. I'm particularly happy that your completeness and timeliness have improved over time, and quite a number of other achievements that you have scored in Sierra Leone. So at this point in time, I did like to invite Dr. Waziri also to share her thoughts. So advancement in technology, Dr. Waziri, have resulted in the innovative and non-traditional use of data to improve the delivery of critical services. For instance, could you elaborate on how AFINET is using data in non-traditional ways to improve vaccination coverage?
Thank you very much. Thank you very much, Dr. Gumbe, for the question, and good evening, colleagues. So I would like to just write on what my colleague has said here. She talked about the DHIS2 that is being used for reporting. In Nigeria, before 2014, we were reporting routine immunization data through a paper-based reporting platform. And we realized that we were getting very high administrative coverages for our antigens, yet we were battling with several vaccine-preventable diseases, notably even the wild polio virus. We were struggling with it. Yet if you look at our coverage on the paper tool, you get coverages of up to 90% for all the wild polio, for all the polio antigens. So the government thought of what can we do to ensure that we get good data that can guide decisions that we make. And we stepped in as AFINET to say we can build a specific routine immunization module on the DHIS2 platform. Test it, run it, learn lessons, and then scale it up. So that was what we did in 2014. We developed a specific routine immunization module on the DHIS2 platform. We tested it in one of our states. Nigeria has 36 states, and plus the FCT, making it 37. So we tested it in one state for a full year. We learned lessons for improvement, and then we scaled it up nationally. After the nationwide scale-up and reporting for about another year, the government adopted the tool as the only reporting platform for routine immunization, because it had several checks and balances. You cannot be reporting 100% when you still have vaccines that you haven't used. So there was a coordination between vaccine doses used and children immunized or children vaccinated. And then following that, the successes of DHIS2, we now had Ebola outbreak same year in 2014. And we, as AFINET, supported the response to Ebola outbreak in Nigeria. During that response, we all know that very important in Ebola response is contact tracing. The ability to be able to follow up all contacts and pick up contacts that are becoming symptomatic immediately out of the community to prevent secondary spread is very key to stop the spread of Ebola. So we sat down again and thought, what can we use to help us know that there is a contact that needs to be picked up immediately? Because waiting for contact tracers to go to the field, they follow up the contacts and then come back to the coordination center to provide their feedback, then you review Then there's a contact that is already symptomatic. People are getting in contact with him. The spread continues. So we thought of developing another platform that will help in monitoring contacts closely and quickly. So we developed, it's just a very simple tool. But post the Ebola outbreak, we realized that this is a tool that can be built on, this is a tool that can be further strengthened to support surveillance and outbreak response within the country. So we got some funding from the Robert Koch Institute and developed a platform that is now called the Surveillance Outbreak Response Management Analysis Tool, SOMAS. So we developed SOMAS, and SOMAS currently is being used by the National Public Health Institute of Nigeria as a reporting platform for outbreaks, for surveillance, and for all the response that is being done locally. I'm taking us through history of all the platforms that we have developed. And then lastly, part of the tools that we developed during the COVID pandemic, when we rolled out when the vaccines got to Nigeria and we're rolling it out, the government reached out specifically to Affinet. You've been able to support us with these various tools that we're using. Can we have another tool that we can collect real-time COVID vaccination data so that it's available real-time? We're able to see where vaccines have reached, who is being vaccinated, and who is yet to be vaccinated. So we developed the electronic management of immunization data. It was also hoisted on the DHIS2 platform. So we had these three tools that collect data at different levels for different programs, but they weren't interoperable. So we thought of how can we get these systems to be interoperable. If I'm putting on surveillance data, how will the immunization data tell me that the reason why we're having vaccine preventable diseases outbreak in a particular locality is because we have a lot of zero-dose children in that place. And that is where the DHIS2 RI model comes in. So we, working together with the US CDC, started the growing expertise in e-knowledge and skills, that is GIGS. And one of the products of GIGS is the data triangulation and also data visualization, but trying to find a way to get all the three systems to be interoperable. So that's being done. We don't thought of it. We have the system, we have the platform, but the data isn't also there. What can we do to get our healthcare workers to report data routinely and timely? What can we do to get data? Because without the data, you can have the platforms, you will still not be able to take decisions on time that will, prevent outbreaks. So we thought that many things have been done. There are many things we've done traditionally over and over and over again. What other things can we do to get the healthcare workers to report? And we came across the FOG model that talks about ability, motivation, and prompts. A lot of times the ability is there, the capacity is there, you just need a little push. So what is the motivation that will push you to report your data? And then what prompts do you need? So the motivation is there. Do you need an additional prompt? So we looked at motivation. If healthcare workers are paid timely, if I get a reward for reporting timely, will that be a motivation for me to report, to be timely in my reports? And then we institutionalize a reward system at the lower level. And then we thought of the prompts. So we went to the community. We have, in Nigeria, we have what we call the ward level, which is the lowest administrative level in the country. At that level, we got some ambassadors. We call them ward data ambassadors that serve as prompts in health facilities. So they go to the health facilities within their locality to remind the healthcare workers to report their data. And then we also got a group of youths that we have in country. So in Nigeria, if you go through a higher level education, you must serve the country for 1 year before you get legally employed. So that 1 year service is called the National Youth Service Corps. So we they are always available because every year you have universities, you have higher institutions turning out graduates, and they must serve the country. So we said that pool of human resource we can also use them as prompts. So we got them, we built their capacity to be able to go to the facilities, to remind healthcare workers, to report their data. And over time, we saw an improvement in reporting. And because of the improvement, we're able to say in these areas we have high numbers of zero dose. Can we prioritize vaccination campaigns in these areas? Can we prioritize even strengthening of routine immunization in these areas? Even the zero dose program now that we're running in Nigeria is also leveraging the fact that we're able to use our platforms, but also able to use these non-traditional ways to find out where we have large number of unvaccinated and under-vaccinated children and get them vaccinated. Thank you.
Thank you very much, Dr. Waziri, for that comprehensive and cross-cutting response as regards the use of technology and also non-traditional methods for early detection and outbreak control. I'll move on to the next and final panelist, that is Dr. Banda. I know Dr. Banda in Zambia, it has been said here many times, even during the first panelist session, that Zambia has actually experienced a number of outbreaks, cholera and other outbreaks. How has Zambia leveraged data and technology in managing the recent cholera and other outbreaks? Over to you, Dr. Banda.
Thank you, Dr. Notion. Yeah, so Zambia, just like Sierra Leone and Nigeria, they are implementing the district health information system too. And I'll give an example of cholera, as you have already alluded to. We have several outbreaks apart from cholera. We've had outbreaks of measles, anthrax, and foodborne outbreaks. But we use example of cholera in terms of technologies. Yeah, so the DHS2 ideally designed to collect aggregate data, but there have been some enhancement that has been done to improve data collection. As you know, for DHS2, the analysis is like on a weekly basis. And especially in the rural places where they don't have access to electricity and internet. So in terms of information transfer, it's usually on paper-based. So now with coming in of DHS2, we have enhanced it to add other modules that can give us real-time data and utilize other platforms like the epidemic intelligence from open sources, a platform created by WHO. So we have a team in the nation that runs that platform, and it feeds the event-based surveillance system that is enhanced in the DHS2. And also within that, we also have the SMS messaging system in places where we have no access to internet connectivity, but we are able to send the short messaging system. That also feeds the DHS2. Then also we have a call center where the communities are able to just call in and provide information. So during the cholera outbreak, we saw a success of the event-based surveillance system where the communities were able to call, send SMSs on the alerts in the community. As you know, cholera, there's some stigma to it. So some of the patients don't report to the facilities with fear of being stigmatized by the neighbors that they are dirty or they have poor hygiene and things like that. So that short messaging system, as well as a hotline, really assisted in capturing the additional number of cases that could have been missed by the usual surveillance system, the IDSR, which is also within the DHS2. So that system captures information from the facility, but the event-based surveillance also captures from the community. And so we saw a success in terms of the number of cases. The outbreak was huge. At the same time, Zimbabwe was experiencing the outbreak. We were also experiencing an outbreak of cholera. And for our country, we had a drought, as well as some heavy downpours in between those spells of drought. So that made the cases to increase exponentially. And so when it came to data for decision making, it was difficult because most of the data was incomplete. And so Zambia National Public Health Institute, working with the Ministry of Health and other agencies, made sure that they enhanced the DHS2 even more. They developed another module, the cholera tracker, to capture patient-level information. For DHS2, originally, we just had like aggregate data, so we just have information of the number of cases, and that's it, and the number of mortalities. Now, with the cholera tracker, the beauty is it collects patient-level data, geospatial information, and other risk factors for cholera. So it was able to inform the incidence management system at national level, when to where we are having the hotspots, so the analysis could be done where we do spatial analysis, and then the incident management system, the one responsible for managing this outbreak, was able to pre-position the commodities for cholera, including human resource and finances. And we are also able to do real-time analysis of the outbreak. And so from that success, we were able to understand what was going on, and it also informed the ministry, and they realized that, okay, we've prepositioned, we know where the hotspot is, but however, we keep seeing more cases. So that prompted the Ministry of Health and advised the ZNPHI, the Zambia National Public Institute, to conduct further studies to understand in depth why we were having these cases despite prepositioning and a robust response to this outbreak. So in terms of technology, I think that was a very good innovation in terms of the importance of having real-time data. And also, from those studies, we were able to understand that, okay, we need also to find a way of monitoring the commodities we've put in the communities and the interventions. How are people getting the messages correctly? Do they know that these commodities are in their communities? And one key, especially for cholera, is rehydration. So the ministry had set up a number of oral rehydration points, but the issue of access was a challenge. So from those studies, informed by the information from the event-based surveillance, we were able to know that despite us putting all these interventions, some communities were not aware of the interventions that we've put in the communities. So we developed another tool to manage the commodities as well as the emergency water that was supplied through a Microsoft application platform called Power BI, linked to a Kobo Collect 2 questionnaire. So we had a number of partners, including UNICEF and others, who were now collecting data in the communities. They'll go to where, like, we've prepositioned a water tank and check if there is water in that tank, how long the water lasts within that emergency water tank, and also measure the level of free residue chlorine. As you may know, if water has too much chlorine, people also won't drink it. And if it has less chlorine, it will still pose a challenge to the community during that cholera outbreak. So with that Power BI, it was visualized and shared with all the partners responsible for making sure that people have access to water, the Ministry of Sanitation and Green Economy and others. So they were able to have access to that data in real time as well, and so they would know that in this area, the water has run out, or the water is over-chlorinated, or it's normal chlorination, and make that real-time decision in terms of cholera management. I think, Chair, I'll end there.
Thank you, Dr. Banda, for those insights from Zambia. At this point in time, I want to give this opportunity to our esteemed participants to ask questions if there are any. Maybe you can just show by raising your hand so that we can see how many people can ask questions. I can see there 1, 2, okay, just go ahead. Okay, so if I can just kindly ask you to just ask one question per person so that we can also give others an opportunity.
All right. Good afternoon, everyone. Thank you to the speakers for your presentation. I have one question to ask. I think one common thing with usually case-based online platforms is data quality and data completeness. So I wanted to ask the speakers, based on your experiences, what are the best ways to basically checkmate some of these things? Because we've had outbreaks in the past. I'm from Nigeria, by the way. My name is Benedict. And usually there is always the issue of data quality and also data completeness, especially in outbreak settings. So how do you, based on your experiences basically, how do you tackle or how have you tackled these issues basically in the past? Thank you.
Thank you. Go ahead.
Good evening to everybody. Trish, I am a student also at UTT. Permission to you, I have two questions. I can't decide on which one. Through you, chairperson, may I please ask my questions? You said one, but I have two.
Decide one.
Okay, mine would go with regards to Sierra Leone, where we spoke about digitalization and also integration between systems, and which I feel is a very good strategy. I just wanted to find out with regards to the usage of GIS hotspotting, how has it been beneficial to your country with regards to case notifications or identifications of any outbreaks?
Okay, let's have the third one, then we can respond.
Hello. Okay. Good. Okay. Good evening, everyone. My name is Abiola from Nigeria, also FELTIP fellow. I just want to ask or confirm how you do, maybe, is there alternative for maybe when some of the application is not working, do you have alternative to have your data incorporated inside that system? Thank you.
Okay, so let's give an opportunity for our panelists to respond. Then we can take another round.
Thank you for your question. I did not understand your question, but just to answer his question, for case-based data, to avoid so much data quality issues and also to deal with completeness, it comes with a design. So initially the design considers things to do with, you do with skip logic, validation rules, you put program rules to ensure that in case there's any data that is really important, it needs to be mandatory so that users do not skip such information. But also things to do with errors and warnings. You have to set up errors and warnings to avoid users making mistakes while entering data. And this caters for the quality of data and the completeness. That's one. And two, for Sierra Leone context, how we are doing it is that we do a lot of monitoring this data. We have a team at national level and district level that focuses on data that comes in. First is if a notification comes in, an SMS is sent to the different levels, the district level and national level. So they are aware there's a notification of this particular suspected case. So they go into the system and, check out for all the issues. Of course, this may not happen on a daily basis, but data is monitored at least on a weekly basis so that all erroneous issues and all data quality issues are catered for before it accumulates. And this is the same during an outbreak because analysis is done on a routine basis. So this minimizes accumulative errors in the system. Then I'll ask her to repeat the question because I didn't get it.
Where is the...
Yeah, he was.
If you can just make it precise so that she can understand this time.
All right, no problem. So my question is with regards to the geographical information systems that is used for hotspotting. So you spoke a lot about integrations of system and digitalization. So are there any lessons learned that has been picked up in your country before, or if you've implemented this particular system?
Okay.
Is it clear?
Yes, it's now clear. In Sierra Leone, we use DHIS2, the GIS embedded within DHIS2 that is used to pick coordinates wherever cases are being notified from. We are not currently using any external geographical information system out of DHIS2. We use the one embedded within DHIS2 to pick coordinates. It's not an external one. I hope I've answered your question. I'll give an example of during COVID. During COVID, we used that functionality a lot, especially when it came to contact tracing and also the suspected cases within the community. It helped a lot because we were able to tell where the cases are located and how many people are in contact within that, that locality. So it helped a lot. But in the routine, it's difficult because the cases are coming from health facility level. So we don't usually use it in the routine. We don't make any impact because we shall not know the exact location and community where the case is coming from. Thank you.
Okay, there was a third question, right?
Yeah.
On that side, yeah.
Yeah, so thank you very much. I think there was a question around opportunities for late reporting, if I got the question right. So for reporting on DHIS2, reporting routine data starts on the 1st of the next month for the preceding month, and it's open up until the 15th of the next month. So and that is when we can say that the reports are timely. However, it doesn't close. So you can still go ahead and report. The only thing is that that report will not be considered as a timely report because it means you must have reported late. So the platform doesn't close. In terms of server downtime, if there's server downtime, there's still an opportunity for you to report once it's come up. We all understand that technology sometimes fail, but as much as possible, there are teams of experts that both at Affinet, so speaking from Nigerian experience, both at Affinet and at the government level, but also at the, there's an organization called HISP. I'm trying to remember their full name now, I don't remember, but they are the main host of the DHIS2 platform. So they also have a team of experts that sit and monitor the server so that once there's a downtime, there is an alert that goes out. So within a short period of time, that is usually rectified.
Thank you. I'll take another round, just probably 3 more, then we can, yeah, this side, let's have this side.
Okay.
Oh, you're there, okay, go ahead.
Thank you, Amadewale Moses from Nigeria. Want to ask, is there any effort made to ensure government support data management? For instance, the SOMAS. We will be using the SOMAS in Nigeria for a while, and it has actually helped. But we observe that at the lower level, the issue with data, most of these healthcare workers don't get a salary on time, and we expect them to also upload data into SOMAS. So I think the government needs to take, what I mean, the government, the state governments, and also the SOMAS. Can we work towards ensuring we can upload data offline instead of online all the time? Because some of these places, there's no network. They have to go to a place where there's network. So I think that will also help if SOMAS can work offline and also online. Thank you.
Thank you. Let's have another one there at the back.
Yes, good afternoon. My name is Dr. Levi Cheptoyek. I'm from Uganda, an MS fellow in epidemiology and biostatistics. My concern actually goes to Bridget. You talked about having a surveillance system that is able to detect outbreaks within 24 hours. So my inquiry is, does it only detect outbreaks in human health, or it also integrates outbreaks in animal health, environment, or even plant health? And then I don't know in your country whether you have priority zoonotic diseases in your country, and how are you managing that surveillance? Thank you.
Thank you. Can we have one last one here? Oh, there was someone there. I see you have 2 mics, so. Yeah, so it was this side, so let's go the other side.
Okay, thank you. My name is Amanda from Uganda, and my question around data is about the security. I think from the example of Sierra Leone, one of the plus things, or the advantages is that you said it's even more available for people to publish, and I think that that's a good thing. But on the other end, is there any, for each of the data bases, is there a plan to protect that data? Because now it's more available. What things have you put in place to make sure that confidentiality and things around that, you know, are catered for? But also to the people that want to publish the data, how have you ensured that they have access to it? Yeah.
Great. I'll have one bonus one, since his hand was up. Then we will wrap it up.
Thank you for the bonus. My name is Mark Madeka from Kenya. The topic for this discussion will add a One Health concept in it. And I will be directing my question to Banda from Zambia. You talked about anthrax. The DHIS2 probably will capture more of the human side or the human aspect of approach. How, in your response, do you allow integration between the animal side, probably, you know, if there is an environmental aspect into that concept? Thank you.
Thank you. Okay, so our panelists will respond to those questions. The issue of SOMAS, government support, offline, and so forth. Yeah.
On the issue of SOMAS and being able to report offline, I think this is still work in progress. It's something that is very possible. Most of these platforms have offline versions that you can work on, but work needs to be done on that. For the DHIS2 routine immunization module, we tried to have an offline version, not really an offline, but we developed like a short messaging service reporting system whereby healthcare workers are able to report their data using SMS. And because it's been programmed, it goes straight into DHIS2. So that we can look around that, but then it needs a lot of funding, right? Because everything needs to be funded. If it's not funded, it doesn't, it won't get done. So Dr. Patrick made a call for funding. Funding is very, very key. Government ownership. Government owns SOMAS. So partners are already supporting it. It is government owned fully, and that is why that's the tool that is being used to report national outbreak and surveillance data in the country. SOMAS is not owned by any partner.
Great. You want to address the issue of data security?
Yes, for the data security and protection, access to data, the country has protocols and procedures that have to be taken for someone to access data, even if it's a resident or a trainee. You have to go through specific procedures to access the data. That's one. And then two, the personal identifiable information is not part of the data that is given to the resident or whoever needs to use it for research purposes. That is not shared. It's just kept within the database, and just to protect the confidentiality of the patients. And then access, if you're not a routine user of this data, you don't get user credentials to the system. And if you are, for example, if you are one of the either district or national surveillance officers that use the data routinely, you'll have authorization, you'll have a username and password to access the system, but you access specific information. You don't access point of entry data if you're a surveillance officer. You don't access likewise. So that is how we manage the security and confidentiality and protection of the data. Then the question on One Health, we have zoonotic diseases that are part of the priority diseases that the country monitors. Zoonotic, those are both human and animal, but animal-only diseases, they use a system called IMPRESS-I. So the country has started efforts on integrating the DHIS2 and the IMPRESS-I for the animal surveillance system. While for the environment, currently environment is still using paper-based. They have not yet developed an electronic tool, but efforts are ongoing to see that all these are combined. And currently, the country is working on a data warehouse that will pull all data from all these different sectors into one central place for analysis and all other purposes for decision making. Thank you.
Thank you, Bridget. Dr. Banda?
Yeah, sorry, thank you for that question. So in terms of reporting from human and animal health, interoperability of the reporting tools for animal health, the electronic reporting tool, the DHS2, is just being piloted in the country. So currently, the reporting is paper-based. However, for event-based surveillance through the epidemic intelligence through open sources, the short messaging system, and the hotline, they are able to capture even events in animals. Say if animals are dying, this information is being captured in the DHS2. But for the routine data, that's when the DHS2 is being piloted, and we are working to make sure that in future we'll have just one system with modules for animal, human, and others. So I think that's what is happening. So, but currently, just for event-based surveillance, that information is being captured. Thank you.
Thank you, Dr. Banda, and thank you to all our panelists for those responses. Unfortunately, I can't take any more questions because of our time limitations. I would want to then shift gears to probably wrap this up with your final thoughts as panelists. Just under 2 minutes, just tell us, maybe share some lessons learned from deploying these innovative technologies for data management and surveillance. What are the main challenges and so on? And what is the way forward? In under 2 minutes. I'll start with you, Bridget.
Yeah, thank you. There are two major challenges that Sierra Leone has faced in this implementation. One is dissemination of laboratory results. However much we've had about 40% of the laboratory results captured into the system, which reaches the clinicians faster, the other 60% would be missing. And so it is difficult to give the clinicians the next steps, whether it's a positive or negative. If it takes long, it is difficult for them to make a decision. And so the solution, we've been on this discussion for the past 5 years. And the lab have systems that they are using to have these results generated. So it's difficult for them to have this data entered, have it in their system at the same time, enter it on this other side where it links with the surveillance data. So, and then this is when the integration and interoperability came in. So the plan is to have the data linked from the lab information system directly into the surveillance system. And then the other challenge is that any information system, including the one for Sierra Leone, which is case-based, is quite resource intensive. It requires infrastructure, it requires, different resources, equipment, and so on, even human resource, trainings, and staff keep on leaving jobs and so on. So this calls for strong collaborations among different stakeholders and partners to see that we are able to have these systems that we all desire for us to have data that would help us make decisions. Thank you.
Okay.
Yeah, thank you very much. So some of the lessons that we've learned is that most often than not, government-owned, community-led interventions are almost always successful. Because if the government owns it, they will provide everything that is needed for it to work and function optimally. If the community drives it, they will use it optimally. So government-owned, community-driven initiatives are always, almost always successful. Some of the challenges that we've seen or we've had is, First of all, is the human resource for health. There's usually a very high turnover of the human health workforce. You come today, you build capacity, you come back tomorrow, you have a new set of persons, you start all over again. So that is a real challenge in, at least for us in Nigeria. I don't know if it's the same thing across the globe. So we have to think of sustainable ways of workforce development so that we don't find partners doing the work that the government is meant to do. And then lastly, some of our way forward is, like I said, what can we do that is sustainable? Get government to own those interventions. Get government to own the initiatives. All these platforms that we use in Nigeria are government owned, and that is why up till now they are functioning optimally. Thank you.
Thank you.
Yeah, thank you. Yeah, so when it comes to outbreak response, I think having real-time data that is needed at a particular time is important, and I think from the discussion, the issue of integration of the platform that we are using is important also in terms of having one system that can manage that information is also a key lesson that I think we can learn from using technology. Also, these platforms and all the technologies can't work on their own. The community we serve and the health workers that use these technologies need to be trained, need to be brought on board to enter that information. You can have a very good system, but if you do not have the information, and it won't provide the service that you designed it to do. So in terms of challenges, I think it's the same issues. Maintaining these systems is a costly adventure, and so that's a challenge. Network connectivity, I think in our country the coverage for network is still very low, so where we do not have connectivity, it's difficult to report. And also the high turnover of staff, I think it's still the same issue. We keep training, so sometimes we even wonder, when are we going to stop these trainings? Because the high turnover is just too high. So you find once you've trained people, after a year or two they've left, and so the reporting still remains to be poor. In terms of way forward, I think government needs to continue supporting the systems and own these systems and invest in these systems. And also I think there was a question on security. If government owns this system, I think there will be some confidence from the public that the information that is in the system is secured, as opposed to a private or partners managed system. People may not have the confidence. I submit, Chair.
Thank you. Thank you, Dr. Banda, and thank you to all our panelists. I think it's quite clear what is coming out in terms of cross-cutting issues, government responsibility, domestic funding. I think that is very clear to all of us. At this point in time, I just want to take this opportunity to thank all of you for making time to be here. Also want to reiterate what Dr. Patrick said earlier on, that you chose this one above all other workshops. It's quite appreciated. We really don't take that for granted. And above all, for staying until the end. You know, we thought you would go out and stuff like that after the first session, but you stayed on until the end. So really, this is commendable. Thank you so much for your support. And we look forward to more collaborations like this one with AFINET. We are there to collaborate and make sure that we build resilient health systems in Africa that we so desire. So another round of applause to all our panelists. So at this point in time, I'll call upon Rachel for the next item on the agenda.
Thank you very much, Dr. Notion. Let's also give him a round of applause for moderating a very great session. would like to have a summary, just for you to take key points from our session. Dr. Christine will just give us in less than 2 minutes. She'll just give us a summary of. Yeah.
2 minutes? I beg for like 3 minutes, 3 to 5 minutes. Anyway, so field epidemiology is about mentorship. So I've been mentored by Dr. Patrick Nguku. Since I have the floor here, really, it would be a disservice if I stand here and I don't mention that I am proudly a graduate of the Uganda Field Program and a scientific editor for the Journal of Intervention, for JEF, the Journal of Interventional Epidemiology and Public Health there, which is the Affinate Scientific Journal. So I thought that should come out, and we welcome you, all of you, to submit your papers to our journal and support us in peer review and all. Yes, so I'll summarize this workshop in about 6 points in what we call call to action, strengthening global preparedness for pandemics through strengthening field epidemiology. We've seen that, and we've all experienced that COVID-19 will probably not be the last pandemic. So we should be prepared now for the next pandemic that will come. And the best time to prepare is now. So, and we think in our call to action, the first point is investing in workforce development. So Affinate's experience shows that building a strong, locally trained field epidemiology workforce is critical for timely and effective pandemic response. Therefore, we call upon countries to work towards attaining the Global Health Security Agenda recommendation of at least a field epidemiology per 200,000 population to ensure that there is adequate preparedness, pandemic preparedness. Our second call to, help me with that. Our second point is support and expand Affinate Corps of Disease Detectives, ACCORD, which is a voluntary professional service of culturally competent field epidemiologists. ACCORD needs sustained funding and resources to be able to quickly mobilize for national as well as cross-border response. This model is vital in addressing outbreaks that we have, like we've seen, EVD, cholera, mpox, name it. Technical support for VPD surveillance and strengthening efforts towards reducing zero-dose children and all. However, there are frequent funding shortages, and these hinder timely deployment. The third point is that we need to strengthen outbreak response funding mechanism. So Affinate's pilot of the Outbreak Revolving Fund in Nigeria has successfully mitigated delays between outbreak detection and response. We think this model can be expanded and adequately funded across more countries to reduce response time and impact, and reduce impact to our communities. The fourth point is to leverage data and technology that is community adoptable and acceptable. So Affinate's efforts to integrate data systems such as DHIS2 for case-based surveillance, as we've seen in Sierra Leone and Nigeria, demonstrate the importance of data in outbreak detection and can also aid in resource allocation. Therefore, governments and partners should prioritize technology adoption and system integration to improve early detection and monitoring of pandemics. These systems should be interoperable. The fourth point, and I think this has come out well, is to promote multi-sectoral collaboration, collaborative efforts with governments, with partners, WHO, Africa CDC, US CDC, the global partners like Gavi, Path, World Bank, and all are essential for sustainable pandemic preparedness. Then ensuring government ownership and integrating public health systems is critical for long-term impact. The last point to emphasize this is that we need to address resources and sustainability gaps. Challenges like inadequate resources, high staff turnover, hinder long-term pandemic preparedness. Therefore, governments and partners must focus on resource mobilization and retention strategies to ensure consistent and effective response capacities. So we think by addressing those 6 areas, we will be able to build a strong, resilient global health system that is capable of managing current and future pandemics. Thank you very much.
Thank you very much. Let's clap for Dr. Christine once again, and for keeping it very short and precise. And ladies and gentlemen, we come to the end of our workshop session this afternoon. Thank you very much for staying to the end. And we thank all the panelists. Let's give all the panelists, panel 1 and 2, a round of applause. And we thank all the participants. Thank you so much for engaging with us and sharing your views and questions. Would like to take a group photo. If possible, you deserve a photo. So we'll have all the panelists join us here, for those who can stand here, and we'll just take a photo from the back and see how many we can capture. We'll try to showcase how many people we